Welcome. I'm WTOP Capitol Hill correspondent Mitchell Miller, and thank you for taking part in the Healthcare Agenda, Real Policies for Real People, sponsored by PhRMA on WTOP.com. And my guest today is Congressman Neal Dunn of Florida's 2nd District. Welcome.
Thank you so much, Mitchell. It's great to be with you.
You are a physician who has dealt with a lot of the most pressing issues related to healthcare, patient care. I wonder, before we get into the details of some really important legislation that's before Congress, if you could kind of outline generally what are some of your ideas of what some of the pressing concerns are as we move forward with a lot of things going on.
Well, there's certainly healthcare. There's no shortage of crisis going through it. Obviously, physician pay, physician training, access to healthcare. Cost is everybody's most painful driver, I think. And I thought today we might talk a little bit about that.
Yeah, and you've been a strong advocate of trying to bring drug prices down. A lot of things going on in connection with generic drugs. I wonder if you could explain a little bit about that.
Yeah, so I think this is the low-hanging fruit, basically. Yeah, so what we have is 85% or so of prescriptions in the United States of America are generic drugs. They go out for written as generic drugs. Now, there are branded drugs. There's certainly some beautiful, great new biologics, very, very complicated. They're still under patent. These are branded drugs that are under patent still. So there's only one producer, one seller. And they have their own set of problems. But the generic drugs is something that everybody takes every day. These are commonly used. And I think the price on these has gotten absolutely out of control. And I think that we can save tons and tons of money, not only in the ERISA plans, the normal healthcare plans that we get through our employers, but also in CMS. CMS is also being just gouged on these plans with the price of generic drugs. And I think we can make huge improvements in that. And it's kind of like a pay for. We're always looking for how do we pay for more access to medicine? Well, here's how you do it. You save $150 billion a year on the cost of generic drugs.
And it seems like there's been some complaints over the years that it takes quite a while for a generic drug to actually be offered to the consumer. I wonder if you could talk about that a little bit.
So there's indeed the system. We all grew up thinking that you had a 17-year patent, whatever, and of course a lot of that time is eaten up in the clinical trials and whatnot. So it typically ends up being about 8 years of time of a drug available, brand new branded drug, great new drug presumably, that's available for 8 years only through the original manufacturer. Yeah, but that usually helps they make up the cost of all the research, which can be phenomenally expensive. However, now they've found special use patents on these that they can kind of roll that along 2, 3, 4 years at a time, and that's getting kind of painful too, because in general, when it's on patent and it has one producer, it's going to be more expensive.
There's a lot of attention, as you well know, about the so-called middlemen in connection with prescription drugs. And I really want to dive into this, specifically pharmacy benefit managers or PBMs. Let's start out with your view on the impact they have had on the cost of drugs.
Well, let me say I've been around long enough to remember when they started out, which was formulary managers, and they literally did manage the formulary for either the end user, like the hospital, if you will, or clinic, or for the insurance plans. So Cross Blue Shield, Humana, whatever, they would hire a formulary manager to actually go out and find the generic drugs cheaply, so get a better price for them, and make sure that there's enough of them, keep the supply going, and then try to get a broad enough formulary so that it satisfied the needs of their patient population. And that was all something that was taken care of as part of your insurance premiums. Now they have morphed off into something else. This is over time, and this is driven by the Affordable Care Act. I want to say that, the Affordable Care Act capped the insurance companies' profits at 15% per year, so they can't keep more than 15% profit any given year on the plans. And so insurance companies say, what can we do to get more profit? Well, they spun off their formulary managers into PBMs. And those PBMs are actually subsidiaries owned by the same people, so but they're not part of that same company. So all of a sudden, any profit the PBM makes can also be kept by the same entity. And that inveigles the PBMs to start bargaining not for lower prices on drugs, but higher prices on drugs. And then they take a kickback from the producer, the actual manufacturer of the drug. And so if you have a drug like Keflex, cephalexin, made by at least a dozen different generic manufacturers, they'll shop around those and ask for not the cheapest price, the highest price, and say, okay, and at the end of the year, you're going to kick back to me X percentage of what I pay you. That's, they don't say kickback, they call it a rebate. This guy's just fees, stocking fees, formulary fees, all these darn things. But basically, what they're doing is say, you want us to buy the drug from you, you have to pay us a kickback, a rebate. Give us some discounts. And I don't want it up front. I don't want the discount up front. I want the discount on the back end because we're going to charge the insurance company ourselves much more price. And then they're going to build that into the premium. So they drive the premiums up. They drive the price of the drugs to the patients back at the pharmacy also way up. And I want to say that this is not just a little bit. And I've actually looked at this, and you can too. This is really easy to do. Next time you get a drug through your insurance company, generic drug, and there are all these. And I said Keflex, it's a common antibiotic. Another common one, zithromycin, made by a lot of different companies. Okay, so you get your explanation of benefits statement at the end of the month, and it says, okay, your insurance company paid $220 for this drug for you to take, but your copay was only $20. So we saved you $200. And you say, great, I was lucky me, I saved $200. Well, had you taken that prescription and gone online to a retail pharmacy rather than to the big box retailer, which is the other end of the insurance PBM pharmacy scheme, all same ownership, had you gone online and gotten that drug, you'd have paid like $5. $5 for the entire prescription. No, wow. No other thing, nothing else there. So I'm less out of pocket paying for the entire prescription myself compared to the copay, let alone I'm going to pay enough in premiums that the insurance company is going to get another $200 covered in the premiums. And they're all going to divide up the extra money. That other $215 is money that they can split amongst themselves or use however they want. Or it accrues to the middle, from the middleman to the aligned vertical structure. So that's actually counterintuitive. I mean, it does not make it cheaper for Americans. Now, I have been doing this. I've been looking at this for the last 2 or 3 years and tracking it. And on average, the increase in price going through the insurance company, all up though, that EOB stated price versus what I would pay online retail is typically 8 to 10 times as much. Not wow. 80%, not 100%, 10 times as much. That's obscene. It's not a crime, but damn, it ought to be.
And you mentioned this, but wasn't the original idea, and this is part of the PBM defense, is that it was supposed to help hold the line on costs, and that was kind of how it was touted to consumers.
Well, and honestly, when they were formularies, I think they did that. And I should say that there are PBMs out there claim, and I don't know, they aren't working for my insurance company. Honestly, that's all I see in PBMs these days. They run the price up, not down, and they take back all that extra money. Can the PBMs get the drugs, for the same as I pay online retail? Heck yeah, they can. They can get a better price even. But that's they what they're doing is actually sucking the money out of the payors, who are either employers, employees, to the extent they kick in on their healthcare premiums, and CMS, who hires these insurance companies to take care of the CMS patients, whether it's Medicare or Medicaid.
Right, Medicare and Medicaid. And now you are on the Energy and Commerce Committee, and you've been working with lawmakers on a variety of bills in connection with this issue. Is part of the
And
issue?
we should say that's because healthcare subcommittee is also energy and commerce.
Right.
It's not
Yes,
in the
that's true.
name of energy and commerce. It should say energy, health, and commerce.
That's true. And related to that, my understanding is that you're looking, among other things, and you can tell me, for more transparency. So all of these opaque things that you're talking about, the consumer and anybody else can understand.
So you could not, you took the words out of my mouth. It's transparency, transparency, transparency. If people knew about this relationship between the PBMs, insurance companies, and big box wholesalers, Rite Aid, CVS, and Walgreens, I guess. There's 3 or 4 more, but that's not many. All in the whole country, maybe 5 or 6. If they knew about these relationships and how they actually cause the cost of cheap medications. But by the way, the manufacturers, pharmaceutical manufacturers of these generic drugs, there's lots of honest, good, hardworking folks out there who can make an honest living producing these drugs and selling them directly to a pharmacy that doesn't take kickbacks, and then on to me at a retail price of $5 or $6 instead of being $200 and $300 for a prescription. And that's just an obscene markup. I mean, we're not talking about somebody taking an extra 10 or 20% vig like the mafia does. They're talking about somebody taking 10 times the money. That's obscene. I mean, it really is.
And so there is pending legislation. I know that some of the legislation has moved forward in committees, but you would like to see it obviously move forward more rapidly.
Yeah, I think this is what, and the trick, you said transparency. Thank you. The trick is people have to see it. People have to understand it. Now, I actually go look for it. I don't think it's that hard. You can look for it too. Again, just compare the prices online. You can shop online. Amazon does there's lots of online retail pharmacy. It's not that hard. And the prices that you find there will shock you. They are so much lower because they're not in that scheme where and so there certainly is an honest market out there for drugs. I don't think that's PBMs and insurance companies and big boxes are. I don't think they're party to that. Now, there's another thing they do too, and this is more on the sort of insurance company and PBM side, not so much the big boxes, and it's called a copay accumulator program. And so you probably get these. You get a prescription from your doctor who says, "Oh, hey, and I've got a coupon from the manufacturer that says you $50 off or whatever." And the insurance companies have worked with PBMs and some of these same big box like Rite Aid, CVS, whatnot, to make sure that the coupon pay doesn't count towards your out of pocket or your deductible. So, in spite of that not being something that the insurance company had to pay for, they aren't going to give you credit for your out of pocket pay. And so that also what that does is just benefits the insurance company, right? It keeps you from appearing to have actually gotten closer to your out of pocket.
And everybody can relate to prices when they go to the pharmacy. Is this something that you see that there is bipartisan support for in Congress?
Absolutely. Absolutely. And that's why it's so frustrating that, we haven't dragged this across the finish line because there's clearly the votes are there for it, but the deep understanding isn't there. And honestly, the public, I think, hasn't tumbled. Healthcare is so opaque. The way we pay for healthcare, the way we deliver healthcare, it's just opaque. And nobody can understand their medical bills. I can't. I mean, seriously, I just had a knee surgery. I don't know. I can't make head or tails out of the bill, you know. And I'm a surgeon, and I've did it for a long time. We need to be able to. People need to be able to look at their bills, understand who's billing them, how much for what, and who's paying, and what the insurance company's paying. And the insurance companies thrive on that opacity, that vagueness, that misunderstandings. So, transparency is the answer.
And we'll see what happens in the lame duck. And then we have a new Congress coming in next year. I'm sure this is going to be an issue. You obviously are very passionate about it, that you're going to continue to fight for.
One of the things we'd like to do is make the country solvent. And if you could save a couple of $100 billion just here on the generic side, we haven't even touched on the branded patented drugs. Today, it's a different set of problems. Also has some distortions in the market, but let's don't confuse, that with the generic drug problems.
Well, it's certainly going to be an issue that we're going to be following. I'd like to thank today's guest, Florida Congressman Neal Dunn from the 2nd District. I'm Capitol Hill correspondent Mitchell Miller with WTOP. Thank you for taking part in the Healthcare Agenda, Real Policies for Real People, sponsored by PhRMA on WTOP.com. I'm WTOP Capitol Hill correspondent Mitchell Miller, and welcome to the Healthcare Agenda, Real Policies for Real People, sponsored by PhRMA on WTOP.com. And I'd like to welcome our guest, Reilly, the Chief Operating Officer for PhRMA, the Pharmaceutical Research and Manufacturers of America. Thanks for joining us.
Thanks for having me.
All right, well, there's a lot of discussion about healthcare, obviously, on Capitol Hill, legislation, but before we get into the nitty-gritty of all that, there's a lot of exciting things that are happening in terms of research and people, of course, looking at a lot of different healthcare issues. I wonder if you could just tell us a little bit about what's going on in the world of research related to cancer and Alzheimer's. I understand that there's continually being some really breakthrough events.
Yeah, well, first of all, thank you for having me. We really are in a golden era as it relates to pharmaceutical innovation. When you think about cancer, we've seen over a 30% decline in cancer mortality over the last 20 years, a lot of that due to the new treatments and innovations that have come along. Lung cancer being one example, 20% increase in survival in just the last 5 years because of the new medicines that have come on board. In the case of Alzheimer's, we're really at the starting point. We finally now have a handful of medicines that are on the market that actually are changing the trajectory of that disease, not just treating the symptoms. And we're just getting started there, which to me is really exciting. Apart from that, we also have exciting new cell and gene therapies that are dealing with childhood blindness, hemophilia, sickle cell disease. So much excitement in the pharmaceutical pipeline. And it doesn't happen, of course, by accident. Our industry invests over $100 billion a year to bring new medicines and treatments to patients. And of course, that's good for patients because the hope is that they've got a new therapy that can help them with their disease. But it also oftentimes leads to lower costs. And we saw that with hepatitis C medicines that were introduced not that long ago that are curative. In just the next couple of years, I think Medicaid is projected to save over $45 billion as a result of those medicines. So good for patients, good for healthcare spending overall. And again, I think we're just at the start of what could be a really, really exciting time in pharmaceutical innovation.
And overall, I know this is maybe an overly broad question, but do you feel like your industry is getting the kind of regulatory support that you need to move forward with these kind of developments?
Yeah, I think that is the case. I will say, one of the challenges always is that science moves oftentimes at a very fast rate, and you need the regulatory agencies to move oftentimes at a similar rate and be up on the science in order to evaluate the new medicines that are coming. But I think, yes, as an industry, there is so much promise for what's to come in terms of the science, but we'll need a regulatory and a policy environment that encourages the new types of medicines to come to market.
And you touched briefly on the costs. Obviously, that's a huge concern for all kinds of people. What types of things are happening to help to lower costs for people who are wondering, why is my prescription going up at a certain time of the year, for example, or over a period of time?
Yeah. Well, I think for a lot of patients, they are frustrated by our healthcare system. We do a patient engagement survey every year to kind of check the pulse of what patients are feeling when they go to the pharmacy counter. What are the challenges they're having? And two issues really pop out from that. The first is that about 4 in 10 patients are facing some sort of access barrier to getting the medicine they need. So their doctor prescribes the medicine, but unfortunately, when they go to the pharmacy counter, they find out, oh, no, you're not going to get that medicine. Your insurance company wants you to start on a different medicine. You need to fail on this one first. So that's one challenge that we hear from patients that they're having. My doctor wants me to have it, but for whatever reason, my insurance company is putting up a barrier for me to get access to it. The other problem has to do with the out-of-pocket costs that patients are asked to pay. We know for medicines that patients are asked to shoulder a larger share out of pocket compared to every other healthcare service, hospitals, doctors, what have you. More of the burden falls on patients as it relates to pharmaceuticals than any other type of healthcare. And that's unfortunate because many patients rely on medicines they go to their pharmacy once a month to pick up their medicines. They're being asked to pay more. The curious thing, candidly, about that is that net prices, the prices that manufacturers receive, have remained essentially flat. They're going up 2 to 3% a year. But what patients are asked to pay at the pharmacy counter is going up much faster than that. And so that causes us, patients and others, to say, what's going on here? Why are patients being asked to pay more than they did just a few years ago? A lot of that has to do with the way that insurance has evolved over time. More and more patients today have a deductible, the amount that you've got to pay out of pocket before you really feel like you have insurance, right? Mm-hmm. Everyone has one that starts at the beginning of the year, and that keeps going up, up, and up. The average family today spends over $3,000 out of pocket before they feel like they have insurance, right? And if you take a medicine, when you go to the pharmacy counter, you hand over your prescription, the price that you pay before you reach your deductible is not the price that's been negotiated between the manufacturer and the insurance company. It's what's known as the list price, kind of the sticker price. If you think about a car, it's like the sticker price. It's the starting point for negotiation. So in that period, patients are often paying well in excess of what their insurance company paid for the same medicine. So understandably, patients are frustrated and they're saying, why am I paying more and more when my insurance company is paying oftentimes significantly less for that medicine? So we think that needs to change. Patients should benefit from the discounts and negotiation that happens in our system, but increasingly today they're not benefiting in the way that they should.
And that gets us to the so-called middlemen who have received a lot of attention from lawmakers, from your industry, from healthcare policy specialists, the PBMs, the pharmacy benefit managers. Could you explain a little bit more about how that works, or in some views doesn't work, in connection with the pricing of what people will pay when they go to the pharmacy?
Sure. So many years ago, insurance companies hired what are known as pharmacy benefit managers to do the job of negotiating with prescription drug companies in order to lower the price of medicines. A laudable goal. We should want someone in the system negotiating with companies to try and lower costs. Over time, insurance companies bought these pharmacy benefit managers, so they're now all part of the same company. Their job is to, again, negotiate with our companies to lower the price of medicines. What is happening, though, in the system, I would argue, is that the incentives that those companies have are not necessarily aligned with the incentives that the patient might have. So, for example, the way that they are paid in terms of the money they receive is based off of that list price of a medicine, the kind of starting point for negotiation, not the net price, the price that the manufacturer receives. So understandably, their incentive is to want as high of a list price as possible because they make more money when the list price is higher. What has that led to? Well, that's led to them preferring medicines that are more expensive when a less expensive medicine may work better for the patient. And those kind of perverse incentives, if you will, are causing lawmakers in a bipartisan way to say something smells funny here. Why is it that these people are making money and making a lot of it, and patients aren't seeing the benefits of the negotiation that they're doing? Because they do negotiate very, very deep discounts from our companies, but if those discounts don't end up with the patient when they show up at the pharmacy counter, patients aren't seeing a benefit of that. So now we have a situation where the Federal Trade Commission, bipartisan members of Congress, bipartisan state legislators, state attorneys generals, patient groups, provider groups are all saying to Capitol Hill and to folks at the State House, something needs to change. We need changes in the system so that patients benefit more from the deep discounts that are in the system, but today are being absorbed by the middleman. For every dollar of a brand name medicine that is sold today, over half of it goes to somebody other than the person that makes the drug, the inventor of the drug, the manufacturer.
Interesting.
Which is kind of crazy when you think about half of it going to a middleman, someone in the middle whose job is not to invent the drug, whose job is not to make the drug, but they're taking a bigger and bigger share each year, and patients aren't seeing the benefit of that. And that needs to change. And
speaking of change, a lot of lawmakers, as you know, are looking at this in terms of a variety of pieces of legislation.
Yes.
What are some of the things that pharma and the industry would like to see happen?
Sure. I think first it starts with transparency. Right now we have a very opaque system, and that opaque system does not work to the benefit of employers who hire these individuals to work on their behalf. It doesn't work on the side of the patient as well, when they have no idea oftentimes when they show up at the pharmacy counter how much they may be paying for month to month. So transparency, it starts there, but certainly transparency alone isn't going to solve this problem. The other area we've been focused is ensuring that the discounts, oftentimes in excess of 50% off of that list price or sticker price, makes its way back to the patient when they show up at the pharmacy counter. It shouldn't be the case that patients are paying more than their insurance company for the medicine that insurance company negotiated a discount. So we would like to see more of the savings passed through, not to the middleman, but to the patient who needs it. And then the other thing that we've been very focused on is delinking their compensation from the list price of a medicine. Obviously, these entities perform a role in the system. Their job is to negotiate to lower the cost of medicine. That's a laudable goal, and we should want someone to do it. But they don't need to be paid based on the list price of the medicine, because what that does is it creates bad incentives in the system for them to prefer medicines that are more expensive, when oftentimes a less expensive medicine may be better for our healthcare system, and it may work just as good for the patient as well. So those three things are really what we've been focused on, certainly as we head towards the end of the year.
Right, and then we'll be moving into the new year. We'll have a new Congress, a new president.
Yeah.
What are some of the things that you're looking at as we move forward into the coming year?
Again, first our goal is hopefully to get some of these across the finish line at the end of the year. That's not a guarantee at the moment. Our hope is that happens. If it doesn't, of course, we'll want the new Congress and President Trump to look at these issues as well. But I would say, it doesn't just end candidly with the pharmacy benefit manager middleman. There are other entities in the system that also mark up the price of medicines, oftentimes without patients, taxpayers, insurance companies being able to do anything about it. And I would just mention hospitals being another one. Many hospitals in our country participate in a program that most people have never heard of called 340B. One of the benefits of this program is that they can buy medicines at a discount, often anywhere from 50 to 99% off. And they have no rules in terms of how they share those discounts they receive back to the patient. So what we often see happening is they buy low and they mark up often 5 or 6-fold. And the taxpayer, in the case of Medicare, or the insurance company, or the employer, or the patient are the ones that are bearing a higher cost. So this is a systemic problem that pharmaceuticals have become kind of a profit center for people in the middle, for the people that buy the medicines, and we need to change that so that patients are the ones that benefit from whether it's the discounts in 340B or the discounts that we provide to insurance companies.
Well, it's certainly an issue that everybody deals with anytime they go to the pharmacy or anytime they deal with a healthcare issue. I think we'll leave it there. I'm WTOP Capitol Hill correspondent Mitchell Miller, and I'd like to thank today's guest, Lori Reilly, the Chief Operating Officer for PhRMA, the Pharmaceutical Research and Manufacturers of America. And thanks again for joining us on the Healthcare Agenda, Real Policies for Real People, sponsored by PhRMA on WTOP.com.